The diagnosis of PCOS must be based on the presence of at least two of the following three criteria: chronic anovulation, hyperandrogenism, clinical or biological, and polycystic ovaries. What androgens should be measured? Ideally, assessments of free testosterone levels are more sensitive than the measurement of total testosterone for establishing the existence of androgen excess. Although levels of dehydroepiandrosterone sulfate are increased in about 30 to 35% of PCOS patients, its measurement does not add significantly to the diagnosis. To what extent should hirsutism, acne, and alopecia be discussed? In adult women, hirsutism, alopecia, and acne are good substitutes of biochemical hyperandrogenism and should be considered as indicating a condition of excess androgen production. How can ovulatory dysfunction be defined? If cycle length is greater than 35 days, it may be assumed that chronic anovulation is present and no special tests are needed. What is the best way to assess ovulation? Measurement of serum progesterone during the mid-luteal phase, days 21 to 22. What are the clinical implications of ovulatory dysfunction in PCOS? Infertility, increased prevalence of endometrial hyperplasia and endometrial cancer. What is the standard technology for evaluating ovarian morphology? Ovarian morphology must be assessed by transvaginal ultrasound. Although transabdominal ultrasounds may be used in the case of young girls or patients from a particular cultural background, ovarian morphology assessment, and, in particular, calculation of the number of small follicles, are less accurate using this technique. What other laboratory tests should be performed in evaluating PCOS? Anti-Mullerian hormone may also be useful for determining a diagnosis of PCOS. However, disorders that mimic the clinical features of PCOS should be excluded by evaluating for thyroid disease, hyperprolactinemia and non-classic congenital adrenal hyperplasia, primarily 21-hydroxylase deficiency by serum 17-hydroxyprogesterone. The hair type present in most women with a hormonal hyperandrogenic disorder is coarse, thickened, pigmented, and long and is called terminal hair. The presence of substantial numbers of terminal hairs over the chin, neck, lower face, and sideburns indicates the presence of androgen excess. The mainstay of first-line therapy for all dermatologic symptoms of hyperandrogenism is OCP therapy. Women with severe hirsutism or contraindications to hormonal contraception may require other therapies such as antiandrogens, spironolactone or finasteride, or mechanical hair removal, laser, electrolysis, etc. Because spironolactone may induce hyperkalemia, serum potassium should be monitored. The use of finasteride therapy should be considered when prior therapy with OCPs and spironolactone are relatively ineffective for severe hirsutism. Finally, metformin is an alternative therapy for hirsutism in women with PCOS who have other indications for metformin use. Although it is useful for metabolic and glycemic abnormalities and for improving menstrual irregularities, metformin is less effective than antiandrogens in treating hirsutism or acne.